Yes,
It's
definitely.
good. It's good. Good evening, everyone. Here Imran Abbas. Again, we are live. So with some break, some short break. So again, we are live, and we have started another interview series, that is metabolic surgery in low BMI, and it is great honor and privilege to interview who is pioneer of metabolic surgery in low BMI at the globe, Professor Alper Cilick. Sir, so much thanks to accept our invitation. Over to you, sir.
It's my pleasure. And I'm so delighted with your words. I have been trying to deal with the field of metabolic surgery for the last 15 years of my life. And I didn't start with bariatric or weight loss surgery. I started with metabolic surgery, with pure control of type 2 diabetes, which was my goal in the beginning of my career. So it was in Japan in 2007, and I was being educated by Dr. Kasama.
Excellent.
And as you know, he's a bariatric surgeon, and he advised me. He gave me two names. You should go and find these two people, and the first one was Dr. Aureo de Paula from Brazil, and the second one was Dr. Surendra Ugale.
Yeah.
which I think you're going to host him next week.
Next week, yes.
Yeah, he is one of the best surgeons and one of the best guy.
Your greatness.
that I know in this world. He's the sweetest of the sweetest, and I love him too much. He's also my teacher. So like searching for a guru in Nepal, I have searched for two pioneers in this field in India and in Brazil. I have been to India 5 times.
Excellent.
And I got my education with Dr. Ugale, and I have been to Brazil 3 times. I got my education with Dr. De Paula, Dr. Ricardo Cohen, and Dr. Luis Berti. And also one of the pioneers in this field. I also feel so lucky to have his education was Dr. Sergio Santoro.
Yeah.
From Brazil. And the last one that I got my education personally from hand to hand was Dr. Nicola Scopinaro. I got educated by him in 2009.
Excellent.
Which was the first few years of my career. And I decided that the pure metabolic surgery can only be an ileal interposition, regardless of weight loss. So after having done, let's say, 5,000 cases of ileal interposition,
Excellent.
we got sparked. But until doing 5,000 ileal interpositions, I have also done RYGBs, MGBs, Scopinaro surgeries, more than 100 each. And let's say 6 years ago, we stopped them. We stopped all kinds of bypasses, all kinds of BPDs, duodenal switches, because people started coming to us with recurrence of their diabetes. Even if they did not regain most of their weights back, diabetes came again. So this was a big problem, you know. My claim was not weight loss. My claim was cure of diabetes, let's say, improvement of diabetes regardless of weight loss. But time has given us the lesson that bypass is not the answer. because I've got bypass cases that I have been following for more than 10 years. You know, their BMI, initial BMI was something around 38, 39. Now their BMI is around 27, 28, but their diabetes is back. And moreover, they are severely osteopenic. And these people started to complain about severe bone pain and pathologic fractures, especially in the legs and in the wrists of people within 10 to 12 years after surgery. These bypass cases started to come to us with recurrence of their diabetes, severe osteopenia, but not too much weight regain. So this has been a problem. But the other problem was the complexity of the Iliad interposition surgery. Because in a classical diverted version of the Iliad interposition, which is the original description by De Paula, in which you divide the duodenum and you have the trimmed stomach underneath the transverse mesocolon. You transfer the trimmed stomach down to the lower abdomen, and there you create 3 anastomoses. And one of these anastomoses is a hand-sewn end-to-side duodenaileostomy. It should be hand-sewn.
Yeah.
Plus 4 mesenteric closures, 3 closures of the anastomotic defects, plus closure of the stomach through the defect that you have created under the transverse colon.
Yeah.
So 3 anastomoses, 4 mesenteric defects, together with a duodenal transection and a trimmed stomach means 3.5 hours.
Yeah.
So you can do it every day. But the good thing was, the very good thing was, no mesenteric hernia in 5,000 cases. No.
Interesting. Yeah.
Right. That is an interesting thing. I don't think that this is something technical dependent. Because in the end, you will for sure have a technical defect, a technical breakdown, but we never had it. There were cases that we have explored due to unidentified abdominal pain, but in majority of them, the problem was enlarged lymph nodes. In a couple of cases, it was adhesions, but mesenteric herniation, none, not even one case. So this was the beauty of this operation. Plus, osteopenia was not severe. No pathological bone fracture, and mild to moderate iron deficiency anemia, that is around 11% of the whole adult population, which is around 7% before the surgery. Okay, but the bad thing about the black side of this operation is, in some cases, what I have seen is unexplainable diarrhea. You know, in a diverted version of the ileal interposition, the total length of the bypass intestinal system is 50 centimeters. Total bypass is 50. So in Roux-en-Y gastric bypasses, where we bypass around 100 centimeters, 120 to 25 centimeters, or in mini gastric bypasses, when we bypass 200 centimeters, this severe diarrhea is a very rare problem.
Yeah.
You know, we had some few cases after MGBs and after RYGB, just one case. But after ileal interposition, we had, let's say, around 1% severe diarrhea. And when it happens, it brings the patient to dialysis, such that severe diarrhea. So people go to toilet for 100 times a day. You know, severe hypertension and leading to dialysis. We have never seen this type of diarrhea in other operations, even in BPDs.
Yeah.
You know, in BPD or in duodenal switch,
Yes.
it is a matter of mechanical length. The intestine is not long enough to suck the material, so people are suffering from a steatoria. Actually, not a diarrhea, it's a steatoria. But in diverted ileal interposition, it's not steatoria. It is something like colitis. You know, the ulcerative colitis patients suffer from diarrhea sometimes 30 times a day.
Yeah.
It is even more severe than that. 100 times of diarrhea. One day. And on the second day, it stops. But these patients suffer from severe kidney injury. And in two of them, the dialysis was permanent. So they had to keep on dialysis. So taking into consideration this kind of severe complication, I call it a complication, I cannot purely suggest the diverted ileal interposition to youngster surgeons who is planning to do this type of surgery to their patients. In the non-diverted version of the ileal interposition, in which there is absolutely no bypass, diarrhea is never an issue, never. And controversially, they are sometimes constipated.
Yeah.
But in the diverted version, whenever the patient starts to regain the weight, they have a severe diarrhea. I can't explain it. And majority of the medical instruments that we are currently using to treat this type of diarrhea, they don't work. They don't correct this diarrhea.
Yes, sir, excellent. So we will go ahead a little with some questions, because in our interview we try our best to engage our guest with question. So it was a really great introduction, especially your journey of metabolic surgery. So, sir, we are into, because I have a lot of questions from viewers, and personally as well, myself and my viewers, we are interested to know about your selection criteria. So then, because in this session, I divided 3 sessions. First, pre-op or patient selection. So next will be technical points. Then I will talk about, so what is diverted, what is this ileal interposition. And third one, then we will talk about post-op and these results that we are talking about, diarrhea or something. So, sir, first of all, so we are interested to hear from your side, because now I am talking with someone whose this metabolic surgery is in tetrafigures, not only in 3 figure, not only in, so in tetrafigure, more than 5,000. This is a great achievement, in my opinion. So we are interested to hear from your side. What is your selection criteria?
Okay. Basically, there are two criteria. Number one, the patient has to be type 2 diabetic. And number two, the patient has to fail to achieve the targets of therapy despite best medical treatment. BMI is never an issue, okay? But what we do when a patient comes to us, we tell the patients to stop all long-acting insulins 24 hours prior to coming to hospital, okay? And oral anti-diabetic medication should be stopped 12 hours before coming to hospital, okay? And when they come to hospital, they come with an empty stomach. They give a blood sample, okay? In this blood sample, we seek for three main criteria. Number one, HOMA1 beta. Number two, quantitative insulin sensitivity check index. And number three, the patient's ability to increase the free insulin level in the plasma. So the patient gives a blood sample and then receives a 400 kilocalories of a standard breakfast. And 1 hour after finishing the breakfast, he or she gives the second blood sample. Okay? So initially, the patient has to show at least 1.5 nanogram per milliliter of C-peptide plus at least 7.5 milli-international unit per milliliter of plasma-free insulin level. And 1 hour after breakfast, he or she should express an at least 40% of the initial levels that have been measured. Okay? So this means this patient has a sufficient amount of proinsulin plus this insulin reserve is still healthy. Okay? If this patient, number one, fails to achieve a hemoglobin A1C below 7.5 despite best medical treatment, or if the patient is clinically or radiologically or biochemically is having an end organ damage. So these are the four main criteria: sufficient insulin reserve, sufficient insulin activity, failing to achieve a hemoglobin A1C level below 7.5, and number four is a demonstrable end organ damage.
Sir, excellent. Sir, yeah. So, yes,
these are the main criteria of our selection.
Because you have highlighted there is a BMI is not important for you. Again, my question, so the least BMI, so if BMI is 19, 20 plus, have you any experience to do surgery for such a cases?
For BMI below 25?
No, yes, below 25.
Yes, a couple of cases, we did it, but why? Just imagine a case.
Yeah.
A 45 years old male with a C-peptide of 1. Okay. Hemoglobin A1C 12 and is smoking heavily. BMI 25, okay? You make this guy stop smoking and you give him 4 shots of insulin per day, okay? 3 months later, his hemoglobin A1C will be something like 7, his C-peptide will be something like 2.5, and his BMI will be something like 32. So this patient is unhealthy normal weight.
Yeah.
Okay. So sometimes we call healthy obese, and this kind of people are unhealthy normal weight people because they are having 2 obstacles that keep them away from gaining weight. One, glucotoxicity associated ketoacidosis. 2, smoking. Okay. And remember, never give your decisions based on C-peptide only. Okay. Because majority of the professional athletes, like the marathon runners or professional boxers, their C-peptide is something like 0.5. Okay, this doesn't mean that their pancreas is empty. This means their muscles are pumping so heavily that they don't need insulin to take the sugar into the muscle cell.
Yeah.
Okay, so C-peptide is something functional. It is situation-dependent molecule. Okay, so in a couple of cases, which we have managed to stop them smoking, okay, and without initiating any kind of insulin regimen, their BMI was 25. Now their BMI is 25 after surgery. So nothing has changed it. Okay, the only thing was they were going to gain a lot of weight, but the operation took them away from gaining that weight. Okay, so the surgeons and the team's responsibility is to define who is an unhealthy normal weight individual. If you can pick those people up in a good way and define that, sir, your problem is glucotoxicity associated ketoacidosis and heavy smoking. This is not your weight. This weight is because of the artificial situation that you have created. Okay, if you make this explanation, they will understand it. But just to keep them away from smoking and give them 3 shots of insulin for 1 month, they will come back to you and say, yes, doctor, you were right.
Absolutely agree, sir. Absolutely. So, sir, really interesting because also personally, I am learning a lot, and in my opinion, this is and definite as my viewers they ask. So, this will be a great session. These interview series, sir, regarding gluten. So we hear a lot gluten so damage beta cell, and due to this, there are a lot of advertisement for barley and anti-wheat. So if a patient is diabetic and type 2 diabetes, so this is due to wheat and something like. What is your opinion, sir?
Well, we as the surgeons have to struggle with the industry of any kind, since this is a very popular topic, healthy feeding and weight gain. There is a very big hidden danger in the gluten topic, in which the companies are blaming the wheat and trying to replace the wheat with rice and corn, which are very dangerous for diabetic people. Very dangerous. Well, so the question is wheat something to blame or not? Okay. If it was the wheat 25 years ago, it was as innocent as San Maria. But the recent wheat, with the changing hormones and changing genetics of the wheat, is not innocent. So the industry has the right to blame the modern industrialized wheat. It is toxic.
Yes.
But a toxic substance cannot be replaced with another toxic substance.
Yes.
So this is the biggest mistake that people are making. If you have a problem with the gluten, then you have to switch to pure vegetables and fat decreased meat. That is your diet. I have stopped eating bread 15 years ago.
Oh my God.
Because 15 years ago, I was in Japan, and Japanese people don't know bread. They don't know the meaning of bread. So I have lost around 17 kilos in 2 months. I said, I'm going to die in here. But time heals everything. And I got used to life without a bread. So it has been 15 years. I don't eat it anymore. I'm so healthy. I feel myself so good. But, you know, sometimes you do something because life urges you to do so, turns into something so beneficial for you. Because
definitely, yeah, definitely, as you mentioned.
Yeah, industrial wheat is very dangerous.
Sir, as you mentioned, definitely in another session, we will talk more about healthy lifestyle. And in my opinion, so a person like you know much better. So regarding, sir, patient selection, we will continue our discussion. Which lab test you have already mentioned? Yes, when patient will admit fasting, and you evaluate how much there is beta reservoir. So with the measurement of C-peptide, and as well as so this is your insulin secretion, and then you so give the patient that's just 400 calorie a breakfast and something, and then measure. So my question regarding, before this, if someone consult to your clinic, have you checked any like C-peptide or other test before coming to hospital? Because before admission, are you prefer to do some lab test for the patient, and then you schedule his surgery or her surgery, or no, there is no need to do any other test for the patient?
No. That is not the case. We do these specific tests in the initial phase. And on the second phase, we do antibodies, anti-iodated antibody, anti-insulin antibody, anti-glutamic acid decarboxylase antibody. These are our musts, okay?
For all patients?
All patients have to.
GAD65, you?
Yes, GAD65, we do that routinely.
Okay.
Because I have seen patients at age 51. She came to me with a severe diabetes, age 51, and I asked her, how many years of diabetes do you have? And she said, it started last year. And this lady was pure type 1.
Oh my God.
Yes. At age 50, it was pure type 1. When we did the genetical analysis, we have figured out that she has a lazy antibody positivity. Lazy autoantibody positivity expresses itself in the late phase of your life.
Yes.
She was pure type 1. And I have seen children at age 12 with pure type 2.
Interesting.
Yes. So the anamnesis of the patients, the medical history of the patients are not reliable anymore. The anatomy and the chemistry of the disease is changing. So we have never seen 12 years of type 2 diabetic, but now we see it. Or 50 years onset type 1 diabetics. I have never seen it, but within the last couple of years, we have started seeing these type of people. So both from the medical legal perspective, okay, and from the patient's well-being, you have to make these analyses routinely, especially quantitative insulin sensitivity check index. You have to demonstrate that the patient is a type 2, has adequate amount of endogenous insulin reserve, and this reserve is responsive to oral food intake.
Yes.
So there was also a mistake that we have made, especially when I was a student. We used to analyze the sugar level and the C-peptide at the second hour after breakfast. This is a mistake. C-peptide peaks at first hour. Okay, that's the reason why we are taking the second postprandial analysis in the first hour after the breakfast. Okay.
Sir, this is excellent. So regarding, because already you have mentioned, because the main issue is autoimmune impact, because when there is autoimmune impact, definite, we will not take the response, and then surgical intervention will be not effective. And also LADA, that is also another issue.
Yeah.
And also we ask it 1.5 diabetes, that is not 1, not 2. How you differentiate LADA, and which patient you suspect maybe this is LADA or no? This is the routine practice to rule out LADA.
Well, as I have said, the autoantibody measurement is a must in our practice. But who is a LADA? Okay. A LADA is a person who is suffering from diabetes for not more than 3 months. Okay. A teenager or a 25, 30 years old young person with a diabetic duration of less than 3 months, in which the patient got the diagnosis in the emergency department. Okay, because initiation of the LADA, the beginning of the LADA is always a ketoacidosis.
Yeah.
This disease has 2 attacks. And in the first attack, majority of the individuals lose around 90% of their beta cells. Okay. And then with the cessation, with the loss of the 90% of the beta reserves, the patient have their first ketoacidotic attack, okay? Sometimes a coma. These people go to the emergency departments with dizziness and sometimes fainting, okay? And one must of LADA is unexplainable weight loss. Okay, a teenager with weight loss, with a very smoky smell of the mouth, and usually faints and is brought to the emergency department because of ketoacidosis. So this is a LADA. You can take a look at the face, okay, and you can understand this is a LADA. So the first attack is usually treated with a single shot of insulin plus a very strict diet for the first month. And after the first month, in 95% of the individuals, you can stop the insulin. Because after the first month, a honeymoon period begins, in which the patient's sugar level is almost normal with no medication, okay? Everything is normal until the second attack. Because with the second attack, the patients lose 90% of the remaining 10%, in which their endogenous insulin reserves fall below 1%, which theoretically means type 1 diabetic. Okay, so most of these people will come to you after the first attack. And in this group of people, anamnesis and the medical history is a great important issue. They will tell you, I have fainted, I lost weight. And one of the essential part of the medical history is a stressful period. Especially in my country, the young males are brought to their military obligation at the age 20.
Yes.
And majority of the LADAs are diagnosed during their application because of stress. And in young females, early marriage is a stress. Okay, when they get...
Yeah, excellent, sir. Sir, regarding, yes, excellent. And we must rule out LADA and definite autoimmune impact. That is the most important, must rule out in such a cases. Because if you will not rule out definite, then the surgical intervention impact will be lesser. Regarding diabetes period, if someone consult to you and so diabetes period is now 20 year, 15 year, but there is a beta reservoir is okay, there is no issue. And after this test, yes, you can see beta reservoir is fine, C-peptide is okay, and everything is fine. But is this time period of diabetes is also effective for the results after surgery?
In the patient profile that you have described, I did their operations. The longest duration of diabetes in my patients was 34 years old. Okay, 34 years, sorry.
Yeah, I understand.
Yeah, so the very good thing about these people is most of them start insulin within 5 to 10 years after diagnosis. So there is something controversial, okay? The earlier the insulin you start, the more you preserve your endogenous reserves.
Definite.
But you get obese.
Yeah.
And your liver early gets tired, because there are three major issues, okay, actually four, which is associated with direct liver injury. Number one, alcohol. Number two, viral hepatitis. Number three, obesity. And number four is hyperinsulinism.
Yeah.
Okay, so the early you start insulin, then your endogenous reserves are brought into a very deep sleep. Okay, they don't function because there is amount of insulin in the bloodstream, so your beta cells fall into a sleep. But sometimes this sleep is very dangerous. Okay, because the reason is, if you take insulin in supraphysiological levels, okay, if your doctor prescribes you, for instance, a long-acting insulin, 24 hours of acting insulin for 2 times a day, and you take it for more than 5 years, then something called pancreatic amyloidosis starts in your body. Okay. So with pancreatic amyloidosis, you can never express a C-peptide above 1. Never. Because pancreatic amyloidosis is something like chronic pancreatitis. Okay. So what the doctor has to discriminate is C-peptide function plus free insulin levels. Okay. If you can observe a 50% increase in both the C-peptide and the free insulin levels in the empty stomach and full stomach period, then this means there is no pancreatic amyloidosis. Okay. So that's the reason to why we have dynamic evaluation, not a standard one, a dynamic one. Excellent. So that I can see the slope in the insulin response of this patient.
Excellent, excellent. So, sir, really, I have a lot of personally no question, but unfortunately, due to shortage of time, so we really amazing. And this is again, I can ask. Yes, you have about 2 decades experience, but still, in my opinion, in surgical world, so this is a new chapter. This is an innovative. And lot of people there, and you can't believe, sir, still our diabetologist in Dubai. So when in different conferences we talk, oh, just no, nothing. Surgery is not effective only in this obese people. Yes, due to weight loss and something. And when I talk again, no, Baba, this is not only obesity. This is also harmonic impact like this, but still need to work more and more. Because this, no doubt, diabetes is real pandemic. This is the real pandemic. Now, no one in every family, so they have someone suffering with diabetes. And if we will not think about this pandemic, just imagine how many people, they will go for dialysis, for stent coronary arteries, for amputation, just with this surgery, if you can. So yes, sir, this is a very interesting. So we will go ahead. And technical question, because I will not take more your time. Just I am interesting after this a huge experience I can ask of this metabolic surgery, and definitely you have experienced different types of metabolic surgery. Now in 2022, according to Professor Alper Cilick, which type is best one?
Such a very difficult question. Well, it was, I think, 2014, right? I have met Dr. Santoro and we talked about his technique, and I said, okay, I'm going to do it. Okay. And I did it. I did around 2,500 cases of bipartitions. The only thing was, could we do something easier, less complicated, okay, and get the same results? We couldn't. Because the bipartition has given me experiences that I have never seen in Iliad interposition. For instance, mesenteric herniation.
Yeah, definitely. There is a defect.
Patients requiring revision surgeries. You can't imagine, around 3,000, more than 3,000 cases of my initial Iliad interposition, no one asked for a revision. But in my 300 cases of bipartition, 10% asked for revision. They said, change it. Thanks God that transit bipartition is something convertible to Iliad interposition.
Yeah.
So we converted 10% of these cases. Malodorous, defecation, malodorous gas production, never an issue in ideal interposition, never. You can never see that, bad smell, never. But in bipartition, 5%. And I am reading reports written by bipartition pioneers, and I think that they are not telling the truth. They said, malabsorption, never a problem. No, you're not right. It is a problem. And what they focus on in bipartition is the width of the anastomosis. That's not true. I have seen 3.5 centimeters diameter of bipartitions with severe constipation, and I have seen less than 1 centimeter of anastomosis with severe diarrhea. So this is not something mechanical. Okay. The major problem about gastroileal anastomosis, where the duodenum is intact and you create a second anastomosis, okay? The major problem about these bipartitions is they are unpredictable. You never know where it's going to go. And this is a huge problem because the patient wants to know what is waiting for him or her. This is a big problem.
Sir,
If I
now,
say,
if
I say 5% revision rate, they will never do this surgery. Okay, so the bipartition has many problems, and my attempts to simplify ideal interposition has found an end. And I said, enough is enough. If there's a kink, it is ideal interposition. Bipartition, not a queen.
Okay, sir, regarding this ileal interposition, definite, you are now explained in detail. So this is the, according to your opinion, this is the best metabolic surgery, especially in low BMI cases, especially. Sir, when we ask low BMI, what it mean low BMI? Till which BMI you ask low BMI? What is your BMI range?
Well, until 23.
Oh, it mean you are doing 20 plus till 23, you are doing ileal interposition.
Below 23, just one case. But our written is above 23. But I told you, unhealthy normal weight individuals.
So I understand. No, what is my question? Sorry, my question is about this, because when we talk about in the most, because this, when we're going to do ileal interposition, because in ileal interposition, there is less chance of weight loss, definite. So what is my question? If patient is suffering with diabetes type 2 with BMI 35, again, you will go for ileal interposition, or no? You will also add something, a surgery that patient also need to lose at least some weight. So this is my question. Till
With
maximum,
a BMI 25, the patients will be 24 after surgery. I mean, the ileal interposition is not a weight loss surgery. They don't lose weight.
So this is my question. Sir, this is my question. So why I am asking again and again, I like to hear from your side for this ileal interposition, maximum BMI, which BMI you will go, then you will, after that, so yes, you can go for mini gastric bypass or Roux-en-Y or another surgery, because patient also need to lose weight. Maximum it is 30, 28.
Maximum?
40. For ileal interposition.
Yeah.
It's good. So this was my question. So I was interested. So if patient with BMI 40 and you will do ileal interposition, is patient lose weight?
Yeah, they will lose weight. They will go to something like 26, for instance. But
this was my question.
Yeah, they will go to normal BMI. But the problem is, in a patient with a BMI around 40, ideal interposition is technically a big problem.
Yeah, mobilizing the intestine and
yeah, the transverse mesocolon is something like this thick.
yeah.
So you need to create a hole in the
Window.
mesenterium.
Yeah, yeah.
Okay, it's a big problem. I mean, it's a technical problem.
Plus,
Plus, majority of the patients with a BMI 40 plus cannot tolerate a 3 or 3.5 hours of anesthesia. You got to go fast.
Yes.
So it is only the technical issues that will prevail me from doing this type of surgery in obese individuals.
Excellent. Sir, regarding technical question, tips and tricks. So, because when you do this, staple this D1 and also trim this stomach, definitely you do gastrolysis and trim the stomach and make a wide sleeve, and then this is a retrocolic. Then you, so where, how you select your small bowel? So which part like this? So from ileal cecal 50, then you staple 150, then you staple, and then 50 from DJ, then staple, then adjust this ileum to the jejunum part. And because this is for my youngsters, they must know what is the technique of ileal interposition.
Okay, after transferring to the stomach, to the lower abdomen, what you have to do initially is to find the cecum. Okay, you find the iliocecal valve and you count 30 centimeters.
30, okay.
You have to preserve the last 30 centimeters of the ileum. Okay, and then you cut it, you transect it. You go for 170 centimeters and you cut it again. So with 2 transections, you will have as 170 centimeters of ileal segment.
Yeah.
Okay. You take this segment out and you take the 2 remaining bare segments of ileum and you anastomose it to each other. Okay.
Yes.
You understand it?
Oh, yeah, completely understand.
Okay. So the bare ileal segment, the proximal end goes to the duodenal-ileal anastomosis, and the distal end goes to 50 centimeters from the trites.
Excellent. Excellent. I take your point. Excellent.
So this way, you would have created just a 50 centimeters of jejunum bypass.
Yeah, yeah.
That's it.
Okay. Sir, another question, there will be any this mesenteric defect. Are you repair these mesenteric defects?
Always.
Yes.
Always. There are 4 defects and they are always repaired, always closed with polypropylene, 3O, interrupted.
Excellent. Sir, regarding this, because always we discuss in different international conferences regarding jejunalization, and also you understand what is my question, because when
Never,
yes,
never,
yeah.
Which is something I am so proud to explain. Never I have ever seen a jejunalization, never. But let me remind you something about the mesenteric defects, because for instance, when you do a gastric bypass, you have a triangle shape defect, right? And you can easily close it in a gastric bypass, gastric bypass, the jejunal segment, okay?
Yeah.
But when you do an ileal interposition, your defect is like this.
Yeah.
Okay? So you have to be very careful in closing it with interrupted O-shaped sutures. You have to pass your sutures in O shape, and when you close it, when you tie it, the defect turns into something like this. Okay, so the mesenteric closure in the ileal interposition is a piece of art. I can tell you that. Very careful.
Sir, what is your position, surgeon position, and how many trocars you use, especially, and what is the site of trocar?
Usually 6. Camera port is slightly to the left and 2 fingerprints below the umbilicus. Okay. And 115, can you see my belly?
Yeah.
115 and 15 from the right side, 112 and 15 from the left part, and 15 mm from the xiphoid.
For liver retraction.
We don't do liver retraction. We just retract the stomach.
Yes.
So, but it's not just for liver retraction. Your assistant uses the xiphoid trocar when you're doing the intestinal anastomosis. He or she is going to assist you through that 5 mm xiphoid trocar. It is very important part of the surgery. Why wouldn't you invite me to do a live surgery in Dubai?
So we can do.
Can we?
Yeah, definite. Because on the base of GLR, we are planning. Really, just I was talking with Professor Amir Khan. Professor Amir Khan is educational director of GLR, Global Laparoscopy and Robotics. And just yesterday, we had a meeting regarding such an activity in Dubai, because now, thanks God, there is no COVID restriction. And,
Alhamdulillah.
yeah,
Alhamdulillah.
and then we can go. Definite. And it will be great honor. And sir, this is the need. This is the need, because now lot of surgeons, they like to see and also hear about metabolic surgery. Because in my opinion, personal, if you delay these side effects or complication of diabetes only for 5 years, not
Yes.
for 1 decade, not for 50, no, only for 5 years, then I am winner. Yes, the patient that was going to do for dialysis, I am not talking for 20 years, I am not talking for remission for life, I am talking only remission of diabetes for 5 years. I am talking delay these complications only for 5 years. Then again, we are winner. And this is reality.
Correct.
Yeah.
Agree.
This
Agree.
is, sir, regarding complication, because now we little talk about post-op. I have a lot of questions. Definite. I will arrange another session. Then we will talk and video session only about technical points of Allele interposition in another session.
Okay.
Sir, my question now, after this 15 years of your experience of Allele interposition, have you any data which percentage of your patient has, at least for 5 years, I am not talking for 1 decade, I am not talking more, complete remission of diabetes for 5 years?
Well, actually, we have this data. Complete remission is around 45-46%.
Okay.
Complete plus partial remission is around 68%.
Excellent.
Complete plus partial plus diabetic improvement is 93%.
Definite. You reduce the dose, so that's
Yes.
improvement. Yes.
Yes.
Sir, which have you experienced any DKA after diabetic surgery, diabetic ketoacidosis, and which patient is prone to DKA, diabetic ketoacidosis after surgery?
Patients suffering from preoperative weight loss are the ones that will develop ketoacidosis. Okay. Whenever you see a patient losing weight, you have to take him or her to the hospital before operation. Okay. And the biggest problem in my country is smoking. So we stop them smoking. We rehabilitate their lungs. Okay. And we do them some pulmonary physiotherapy. Okay. And if you prepare them well, you will never have a ketoacidosis. We had 2 ketoacidosis patients, and both were obese type 1s. So if we did not prepare our patients in the preoperative setting well, I'm sure we would have faced a much more number of patients with ketoacidosis. But our preparation protocol saves us from seeing these people. Sometimes there are patients that we prepare for surgery for 2 months in the hospital, okay, just to prevent these metabolic complications.
Yes. Sir, another question regarding, because now we are talking about post-op. So what is the main concern? What is your main concern after ileal interposition?
Main concern,
Main complication. So because during this 15 years and more than 1 decade, so sometime when I am doing now personally, my main practice is OAGB, one anastomosis gastric bypass. And I know what is my main concern. So bleeding, maybe something like this.
Okay.
What is your main concern?
The main concern is mechanical ileus. Actually, it is not a mechanical ileus. I will explain you why. You know, after your surgery, you will almost have no mechanical obstruction, mechanical ileus after your surgery in the initial postoperative period. The reason is you don't cut the intestine.
Yes.
Okay. There is a very strong vagus nerve-induced intestinal pacemaker activity, in which by doing an OIGB, you don't disturb it.
Yeah.
But I'm cutting the intestine 3 times.
Yeah.
So I'm killing that intestinal pacemaker activity.
Yes.
And due to this intestinal pacemaker activity, the loss of this pacemaker activity, what we see is a late return of the intestinal action. So my patients, in your patients, I feel that you do not do mechanical bowel cleansing. You just say them to take clear diet 1 day before surgery, right?
Yes.
In my setting, it is 2 days. 2 days of liquid plus mechanical bowel preparation. Okay? So if a patient comes to my table with a full intestine, I don't do their ileal interposition. I stop it. So the patient has to understand that the intestines must be empty. Okay? So this intestinal pacemaker, the stopping, the cessation of the intestinal pacemaker activity sometimes may turn into a disaster.
Yes.
If you don't understand it very well, if you don't notice, and if you don't treat it well, it can kill the patient. So
sir, how you deal with such a case? Because definite then patient will face ileus post-op when you will start liquid diet post-op, and how long time patient must stay, and in such a situation if patient is suffering with the ileus, so how you deal these cases?
What you have to do at first is to notice the discomfort and the distension in the belly, okay? And without losing time, you stop oral intake, and with the guidance of a non-air pumping endoscopy, you have to place a red-colored NG tube to the abdomen, to the stomach.
Yes.
But actually not the stomach. You have to pass it through the anastomosis.
Yes.
And lead it to the intestine. That is the only thing that you need to do. But medical agents like pantothenic acid, metoclopropamide, and especially neostigmine are going to help you to reoccur this intestinal pacemaker activity. But as I have said, empty bowel empty bowel is the only cure. You have to empty everything.
Right.
If not, this will lead to an ileostomy.
Yeah. Yeah.
Okay. So you have to be very careful. Follow the patients very meticulously. And whenever you see the signs of a mechanical ileus, you have to put that NG tube into the anastomosis. I mean, through the anastomosis into the small bowel, not the stomach.
Yeah. Sir, so really so much. Again, I am asking because so much interesting, and personally, I know yourself, and it is really great honor for me to have
It's
such
my
a
honor.
legendary. No, really, sir, this is reality. And now I know because this is one of the most interesting topic, especially for our metabolic and bariatric surgeon. And definite, we will have many questions in comments. Definite you will follow, and you will see how much the response will be, because also this will be also at our YouTube channel, sir. At the because really personally I like to continue, but unfortunately due to the time. So one last question: what is your message for our youngsters, or those who are just now going to start pure metabolic surgery? What is your message for them?
Just to understand, just to know that the high value of satisfaction, like you achieve in weight loss surgery, like you achieve in plastic surgery, aesthetic surgery, there's a very high patient satisfaction. They will love you, okay? But when you do metabolic surgery, you will get married with your patients, plus medical industry and the endocrinologic friends, they will hate you. So be prepared, my friend. A big war is waiting for you.
Yeah, agree. Sir, really so much thanks, and definitely we will continue this series till December, and every week this Tuesday evening we will have such a session with someone who are expert in metabolic surgery. And thanks, my viewers, till this time you are with us, and these all sessions is due to your interest, and we need your feedback. And especially if you have any question from Professor Alper Cilick, you can ask personally from myself and as well in your comments, and definite Professor will answer. And next week we will be with another legendary Professor Surindra Ogale. He's also pioneer of metabolic surgery. And definite, we will continue this series every Tuesday, 10 p.m. Dubai time. Sir, again, so much thanks. And definite, I will follow that, so to arrange such an activity in
Please.
Dubai. Yeah.
Let's do it in Dubai.
Oh, I will do, sir. I will do. Sir,
Okay,
again, so much thanks, sir. So much thanks, and have a nice time.
Thank you very much.
Thank
Very
you,
kind of
Thank
you.
you, sir. Thank you, sir. Thanks a lot. Thank you, sir. Thank you.
Bye-bye.